All right, so the urinary system. We talked a lot about the urinary system in lab, so you should be familiar with some of the basic structures like the kidneys and the renal artery, renal vein. Remember, the renal artery brings blood that needs to be filtered into the kidney, and then that filtered blood comes back to the vascular system through the renal vein. Anything that is filtered and destined to leave the body as urine leaves the kidney through the ureter. So there's a pair of ureters that drain, one that drain each kidney leading to the bladder, and the bladder is where urine is stored, and then when it's time to exit the body, it leaves via the urethra. So those are the major structures of the urinary system. There is a gland that sits on top of the kidneys that we're going to be talking about with the endocrine system. It's not part of the urinary system, just the endocrine, and this is the adrenal gland. And you'll hear about that, when we, like I said, when we study the endocrine system. So whatever hormones are produced by this gland, they go to the blood. We also talked about the indented portion of the kidney, which we call the hilum. And what we find at the hilum are the renal artery, renal vein, and the ureters. So functions of the urinary system. Number one function, filtering of blood. So taking that plasma and removing what is considered wastes or excesses, and then reabsorbing and adding back to the blood whatever was filtered out, things that we might need to keep in our plasma. For example, what is one substance that we will never find in our urine if we are functioning properly? Glucose. Glucose should never be in the urine. Our body is very selfish with glucose, never wanting to give up excesses of glucose. Now, if we could design a pill that would allow us to do that, we would end obesity in the United States, because storing of glucose is what leads to excess fat, right? So we never lose glucose. We always reabsorb back whatever is filtered out of the blood. So we'll talk a little bit more about that. Also, the kidneys, because they are filtering plasma, plasma can leave the vascular system and then be reabsorbed back to the vascular system. So our kidneys are very good at monitoring our blood volume. And blood volume determines what major vital that we take on our patients. Blood pressure, yeah. So blood volume goes down. If we lose our plasma, blood pressure goes down. If we add too much fluid to the plasma, blood pressure goes up. So the kidneys play a vital role in controlling blood pressure. So when we want to control a patient's blood pressure, sometimes we'll give them a pill called a diuretic that basically turns up the filtering action of the kidneys, and they pee away excess fluid. And by peeing away excess fluid via plasma through the glomerulus and into the kidney, we bring blood pressure down. Concentration of blood solutes. Anything in the plasma, like bicarbonate ion, potassium ion, sodium ion, those things are filtered out of the glomerulus, entering the kidney. Some of that can be reabsorbed, depending, again, what the needs of the body are. Looking at pH, well, the pH, again, depends on what major ion. What ion determines? Well, bicarbonate can soak up excess hydrogen ion. Yeah, hydrogen ion is the important ion for predicting blood pH. Now, there's other ions in the blood that can bind to hydrogen ion and raise blood pH, and you already mentioned one of those is bicarbonate ion, right? So the kidneys are really good at finding that right balance between hydrogen ion and bicarbonate ion in the plasma to control that blood pH. And don't forget, what is the normal blood pH? I think that's definitely on the final exam. Very good, very good. 7.35 to 7.45. And then blood cell synthesis. Do you remember the hormone that we talked about with the blood unit that increases red blood cell production in the bone marrow? Yeah, erythropoietin, or EPO. That's that one hormone that some people use, we call blood doping, when they remove some of the blood and then they stimulate EPO production. So the kidneys, remember when oxygen levels get low, the kidneys release EPO. It acts on the bone marrow and increases the speed of maturing red blood cells in the bone marrow. So the kidneys are responsible for that red blood cell synthesis. And then synthesizing vitamin D. First of all, we make vitamin D where? Where does it start its production? In the skin. in the presence of UV light, right? We keep waiting for that UV light here. It's going to come eventually. But anyway, so it starts in the skin, but that's not ready to be used yet. It has to go to the liver. The liver processes it again, and then from there it goes to the kidneys, and the kidneys make the final adjustment to this molecule where it can be used in the small intestine. And why do we need vitamin D in the small intestine? Helps us absorb calcium. Yep, calcium and vitamin D are partners in the sense that calcium needs that escort with vitamin D to get out of our digestive tract from the small intestine into the blood. So if you have low levels of vitamin D, we're going to see low calcium absorption. And what would be the symptoms of low calcium absorption? Fragile bones. What other roles are there for calcium in the body? What? Muscle contraction. So we'll see maybe some heart irregularities, muscle contraction irregularities. And what's the third function of calcium in the body we learned this semester? Having to do with blood. Blood clotting, yeah. So if you have low calcium, what can we expect to be a symptom of that in terms of bleeding? Too much or too little bleeding? Too much bleeding. Yep, too thin of blood because we don't have that calcium, which plays an important role in forming our clotting factors and getting to those enzymes related to forming the blood clot. So very, very important body system. A lot of our hospitalized patients that are there for non-surgical related things, when we talk about people are hospitalized because of negative feedback mechanisms gone bad, a lot of them are related to the cardiovascular, respiratory, and urinary systems. Sometimes it's all three. So that's job security for those of us that are going into healthcare, is failing urinary, cardiovascular, and respiratory systems. Some are self-induced, some just happen as a part of aging, some are genetic. So looking at the kidney then, in terms of blood flow, we can see that blood enters in through the renal artery and branches quite a few times until it gets out here in the cortex. And out here in the cortex is where we find that tiniest of capillary, that tuft of capillary called the glomerulus. So this picture here on the right-hand side is the glomerulus that we find out in the cortex. So that's where the plasma leaves the blood and enters into, some of it, enters into Bowman's capsule, which is the nephron. So that's what this structure is here, is the nephron. And then some of that plasma stays in the glomerulus and goes back via the efferent arteriole to these peritubular capillaries, and we'll talk more about those when we get into the nephron in more detail. So basic big picture structures that we talked about in lab. The ureters drain that urine from the kidney, the bladder stores it, the urethra transports it out of the body. And obviously males have a longer urethra than females do, and there's internal and external sphincters at the urethra that the external sphincter is the one we have control over, so it's made of skeletal muscle, and we can control when we want to empty our bladders. And that control usually happens around age 2, physiologically, but as a society, sometimes we say there's other emotional, psychological, developmental factors that we don't always force kids to potty train at 2. But physiologically, a majority of kids are able to be potty trained at 2, some even younger than that. I'm sure you've heard of relatives or yourselves or other people that have trained earlier than that. But physiologically, it is possible. When I look at my kids, for example, 5 of the 6 of them were trained by 2 because it was a priority in our house, because we just, you know, expense-wise, diapers, things like that, it was a priority. But now my last one, she's taking her time, and I'm busier, and I'm not paying quite as close of attention, and she, you know, took a little longer. She is potty trained now, but she's 4. But it took a little bit longer. So it's a personal preference when parents are ready to really get serious, because sometimes parents are busy, or the daycare that they're going to, maybe they're kind of have a miscommunication on, you know, how they're going to deal with potty training. But physiologically, the 2-year-old is aware of controlling those sphincters, because you can see some kids, they'll go and hide in the corner, right? Or they'll be completely dry 1 minute and then completely wet the next. That's a sign of a child that's ready for potty training. Babies, you know, like 1 year or less, are less able, and you can tell that because when you're giving them a bath and you're drying them off, all of a sudden they tinkle a little bit on the floor, just a small amount. That's a sign of them just releasing urine kind of as it's formed. They don't have good control. But when they go a large amount of urine, that means they're holding it back and they have control of that external sphincter. So that's one way to see if your child's ready for potty training, is to see, like, do they wake up dry some mornings? You know, that's a sign that they're controlling that external sphincter. So when we look at urine formation, it starts here in the glomerulus. This is, like I said, a tuft of capillaries that we have leading into the capillary, this coming from the branches of the renal artery. It's called the cortical radiate artery, but you don't have to know the details of this till you get to advanced A&P. But the afferent arteriole brings blood into the glomerulus, and the spaces between the cells and the pores of the glomerulus allow plasma to leak out. Now, plasma only. So what have we talked about all semester? Some things that are too big to be squeezed out of a capillary. Say again? Proteins are one, and another. What else do we find in the blood that's too big to fit out of the capillary? Red blood cells. So those are the two key things to remember. We should not see, or no, there's one more actually. Red blood cells, and what else is in our blood? What? Yeah, white blood cells. So think about that. We should not see large amounts of protein in the urine. You might see some protein in the urine, because we do see a little bit of protein in the interstitial fluid. Not much, small amounts. But you should not see pink urine, right? That would be a sign of red blood cells. You're looking at hemoglobin inside those red blood cells if you see pink in the toilet or in the sample from your patient. So we should not see pink urine. That means red blood cells are in there. And we should not see cloudy urine, because that means that there's red blood cell, or white blood cells in there, I mean. So we should not see cloudy or pink urine, because that's a sign of something abnormal. There's cells in that plasma that shouldn't be there. We do see urine being slightly yellow, and that's because of bilirubin. As a breakdown product of hemoglobin, the heme part of hemoglobin is broken down into bilirubin, which gives urine its yellow color, and that's normal. We would expect to see that. But urine is mostly water, because our plasma, remember looking at plasma when we studied blood, it's mostly water. So our urine should be mostly water. And if it's dark yellow, that's a sign that it's too concentrated, and this person is maybe dehydrated. So we want to make sure hydration levels are up and urine is slightly yellow, but not dark yellow. So this plasma is squeezed out of the glomerulus, minus the red blood cells, white blood cells, and protein. That should not be in what we call the filtrate, because this is not very selective. Filtration here in the glomerulus is not selective. We just squeeze, like when you make mac and cheese, right? You throw the thing into a colander maybe, and you let the water come through, but the mac noodles stay back. Well, that's how the glomerulus is. We let the plasma out. We keep the red blood cells, white blood cells, and platelets and proteins behind. That we want to stay in the blood. We don't pee that away. But we get rid of that plasma. Most of it, but not all, because we see an efferent arteriole leaves the glomerulus and comes down and wraps around this nephron. And we can add or remove things from here after we leave the glomerulus. So there is an opportunity to add or remove substances from either space after we leave the glomerulus. So filtration is always from the glomerulus to the Bowman's capsule. This is the first part of the nephron. So that's a one-way flow. Glomerulus to the Bowman's capsule. It's not selective. Just anything that's in that plasma gets squeezed out. So our sodium, our glucose, amino acids that we need to keep gets filtered out, and it enters Bowman's capsule. So then we have reabsorption occurring. That's what number 2 is showing. We're taking those substances that were filtered out that we need in the blood, and we reabsorb them back to the blood via these little capillaries, these peritubular capillaries that are going to eventually lead to the renal vein and go back to the blood supply. So this blue arrow, very, very important process called tubular reabsorption. We're calling it reabsorption because where was it absorbed first? To redo something means you did it once already. What are we reabsorbing? Where do we absorb that substance first? Let's say we're talking about glucose. What? Yeah, we absorbed it the first time from our digestive tract, right? It entered our blood from our digestive tract, then we're dumping it out of the blood from the glomerulus, and now our body's saying, no, we want that back again. So we reabsorb it back into the blood from the peritubular capillaries. And even beyond there, which we'll talk about. And then sometimes we need to get rid of something. At the end of the circulation, as it passes through the kidneys, we will secrete into the tubule, into the nephron things that we don't want in the blood. So that's this process. So it's very important for all three of these here that you know what direction things are moving. When I say filtration, where is that occurring? In the glomerulus to the Bowman's capsule. So it's leaving the blood. Tubular reabsorption, it's going from the nephron tubule back to the blood. Tubular secretion, going from the blood into the nephron. So definitely know the direction of that substance and have some examples of what are some things that undergo each of these processes. Glomerular filtration, you can just pretty much say anything in the plasma that can fit through the holes is going to leave the glomerulus. Depending on the pressure. Now we talked about different pressures, right? We have capillary hydrostatic pressure, right? That's going to determine how much leaves. The higher the pressure at that afferent arteriole, the more potentially that could leave that glomerulus. Tubular reabsorption, something that would be reabsorbed back. What was one substance we said that 100% gets reabsorbed? Glucose. And another one was amino acids. We don't want to waste amino acids either. And tubular secretion would be things that we want to get rid of. Can you think of a waste product that we would expect to see? When we talked about muscle contraction, we said this was something that gave off a phosphate to make ATP. What? We started with a C. It's found in muscle cells. It's used for energy. Yeah, very good. Creatine phosphate. So it gives off the phosphate, and we have creatine left over. It's a waste product. We don't need that. So some of that might be secreted or remain in the... Or how about, better example, here's a better example. Let's say my pH is too high. Say I'm retaining carbon dioxide because I've got bad lungs, and I want to get rid of an ion to bring my pH up because my pH is too low. Because remember we said CO2 makes acid? What could be something I could secrete to bring my pH up? What's an ion I could secrete here? If I secrete bicarbonate, my pH would go what direction? It would go down further. If I'm holding on to carbon dioxide, I'm getting acidic blood. So I want to secrete into my kidneys what? Hydrogen ion. Hydrogen ion. That'll bring my pH up if I can get rid of that excess H+. Because remember, pH is directly affected by hydrogen ion concentration. So we would want to reabsorb, hang on to more bicarbonate if we have high hydrogen ion levels or low pH. Okay, so looking at the nephron, I love this picture. This is from your textbook. It really shows you what's going on at each part of the nephron. Remember, we have Bowman's capsule here, and then we have the proximal convoluted tubule. Then we have the loop of Henle here. Then we have the distal convoluted tubule, and then the collecting duct. So this is a great power-packed slide here of what's going on across the nephron. We're going to talk about each part as we go along here, but this is a nice summary. So remember, the collecting duct is not part of the nephron. It's kind of just the sewage pipe for individual nephrons receiving its contents. But it also can adjust the contents of the urine based on different hormones that act on the collecting duct. So if we look at, in general though, the proximal convoluted tubule, 65% of the filtrate, the stuff that left the glomerulus is reabsorbed at the proximal convoluted tubule. So over half of what leaves the glomerulus goes back to the blood at the proximal convoluted tubule. So we're not wasting any time taking that stuff right back. And it's 100% of the glucose and amino acids go back to the blood because we don't want to lose that. So filtration, again, non-selective, and most of what is filtered goes back to the blood by the time we get to the collecting duct and out for making urine. So most of it is reabsorbed, 99%, know that number. Only 1% of what's filtered enters as urine and leaves the body. So if we didn't have this reabsorption process happening, we would urinate out our entire blood plasma in about 20 to 30 minutes. That's how much of our blood is being filtered. So when we talk about the filtration membrane, we're talking about the glomerulus. When we say it's fenestrated, it means it has lots of holes, it's leaky. When we look at the pressure that controls the push of that plasma out of the glomerulus, we have this hydrostatic capillary pressure minus the pressure in Bowman's capsule, which would be like our interstitial fluid capsule, or interstitial fluid pressure. And then we have this osmotic pressure, remember, that draws fluid into the capillary. So, oh, go ahead. Reabsorbed. So that's only at the proximal convoluted tubule. The rest will be reabsorbed later on in the nephron. That 65% you're talking about, yeah. The other 34% is going to happen later on in the nephron, where it'll be reabsorbed back to the blood. 65% happens just in the proximal convoluted tubule. So most of that reabsorption, we could say, as a general statement, right, is occurring in the proximal convoluted tubule, 65%, right? Okay, so here, this is really a nice little diagram that shows how filtration, here's the afferent arteriole. Here we can see the substances like glucose, amino acids, water, whatever, leaves the glomerulus and enters Bowman's capsule. But the blood cells and the proteins do not leave. They stay in, right? And not everything is filtered out. We have some protein, or some solutes that remain in there that leave via the efferent arteriole. And again, a lot of what determines what is leaving here depends on the concentration and also the pressure here. So again, this shows the different pressures and what direction they're acting in the glomerulus. So here's the afferent arteriole, efferent arteriole. So the net filtration pressure is just subtracting the pressures that act out of the glomerulus minus the pressures that act inward on the glomerulus. And we talked about this with capillary dynamics, so we're not going to go into the details of that again. But you can see the net filtration pressure is about 10 millimeters of mercury. Depends on the textbook. Some textbooks give it a smaller value, like 7. But it's not a very high pressure. But it's enough, again, to keep things moving out of the plasma to be filtered. So we need to reabsorb this stuff that enters Bowman's capsule and enters the proximal convoluted tubule. How we do that is there's cuboidal cells that line the nephron. Some enter by passive transport. There's channels where it just directly can flow. No energy required, maybe facilitated diffusion. Some are active transport with the salts. We see some of the movement of sodium and chloride is by active transport. And co-transport, we didn't talk too much about that. We're not going to get into the details of that, but that just means that there are transporters for 2 different ions moving in the same direction, or sometimes opposite directions. But we don't need to know the details of how they're transported. That's more like biochemistry, looking at transporters. The key thing that you need to know is that there is some type of transport mechanism across the walls of the nephron. And these are cuboidal cells that line the nephron. So it'll enter the cells of the nephron and then going from there to the peritubular capillaries, or another specialized capillary called the vasa recta, but we'll talk about that in advanced A&P. So other things that are reabsorbed are ions and molecules. Sodium, very important ion for controlling blood pressure and muscle and nerve function we've talked about. Where does urea come from? Urea plays a big role in the kidney in terms of concentrating urine and things, but we're not going to get into the urea transport. But when you hear urea, it is a waste product. It is in the urine. We should expect to see urea in the urine. And there is a measurement that we look at people's kidney function. It's called the BUN level. It stands for blood urea nitrogen levels. And we can tell if somebody's got good kidney function by looking at the levels of urea, which is a waste product. How does it get there? What does it come from? Do you know? What? Yeah, proteins. Did you say protein? Yeah. When we eat protein, our bodies break it down into urea. The liver plays a big role in that, breaking it. It first gets broken down into ammonia, and then the liver processes that ammonia and turns it into urea. Some people with bad livers can't do that step of breaking down the protein from ammonia to from ammonia to urea, and ammonia levels build up in the blood. And ammonia, when it acts on the nervous system, makes people kind of wacko. Makes them, do you ever see anybody with liver failure and they act like they have advanced Alzheimer's? That's because of ammonia levels in the blood. So urea comes from protein when we break down protein. So people that have bad kidneys, should they have high protein diets? Definitely not. They really have to be careful with their protein levels. And if someone has a high blood urea nitrogen, nitrogen is part of protein. So if we have high levels of urea, that's a sign of kidney failure. So this is what reabsorption looks like. So these are different ions that are leaving the nephron and entering into the blood. So in this case, each circle has its own little special name. Sodium, glucose, amino acids, those are things we don't want to lose. So most of what enters the filtrate here, so it's being squeezed out of the glomerulus and it's destined for the urine, but right here in the proximal convoluted tubule, most of that, more than half of that, goes back to the blood. The rest of it is going to be selectively taken out along the rest of the nephron. So this process here is called reabsorption. We're taking it back to the blood. Yes?
So the part that's showing is that the 65% and then over more is the 99%?
The whole thing, by the time we get to the end here, this is where the 99% is reabsorbed. Yep. This is the 65% that occurs right here. Good question. Okay. So we see reabsorption occurring in the loop of Henle as well, but it's more specific to salt, a little bit of urea, but I don't want to talk about urea at the loop of Henle. That's an advanced concept. So we're just going to stick with salt and water. So the only thing that you really need to focus on is when we look at the different limbs, we have the descending and ascending limbs of the loop of Henle. We can see what molecule is leaving the descending limb. So the loop of Henle comes down and then goes right back up to hook up with the distal convoluted tubule. So in the descending limb, which is right here, what's leaving? Water. Water is the only thing that can leave the descending loop of Henle. So what do you think happens to the concentration of salt? It gets more concentrated, doesn't it? So water's leaving in the descending limb, and then that's because the only thing that the cuboidal cells that form the loop of Henle only have the ability, there's no transporters specifically for salts. So only water can leave via the descending limb. Then this is the ascending limb is impermeable to water, but it's permeable to salt. So we see salt leaving on the ascending limb. So the descending limb is permeable to water, water leaves, enters the blood, and the ascending limb, salt can leave, water stays. And that simple process is just something you need to know. We'll expand on that when we get to advanced A&P, looking at how that helps us concentrate our urine. But just assuming that, as we get to the bottom of the kidney pyramid here, closer to the apex, what can we say about the concentration of urine in the nephron at the bottom? Higher concentration. As we get back up to the top, lower concentration. Okay. So that's all you need to know about reabsorption. Just know what are some things that we would need to actively reabsorb. Oops. So secretion now is when we get toward the end of our nephron is where we see most of the secretion occurring. So it's mostly in the distal convoluted tubule and collecting ducts are some of these ions that might be in excess. So hydrogen ions, potassium ions are some examples of things that we can get rid of excess when we don't need these substances in our body because we need the right balance of these ions. Now someone who again has emphysema, is retaining a lot of carbon dioxide, they're going to be having acidic blood, right? That's going to form that carbonic acid, which is going to break up into hydrogen ion and bicarbonate ion, and where they're going to be secreting excess hydrogen ion. We would expect to see more acidic urine in a patient with emphysema because their kidneys are trying to deal with all that excess CO2. They can't blow it off. The lungs aren't good enough to take care of it, so the kidneys are trying to correct it. Okay, so we call that a compensation. We call it renal compensation because they're trying to compensate for this high, or for this low pH, this high hydrogen level, by secreting excess hydrogen ion. Yes?
Well, when your blood is acidic, do you become more thirsty then is your body trying to rid itself of the excess hydrogen through your...
But you're not losing water, you're just losing that ion. So you might not notice excess thirst. Potassium too, sometimes when you want people to urinate more to get rid of high blood pressure, to keep their plasma levels lower, we'll give them medication that causes excess urination, and sometimes they lose some important ions in that process. And one important ion that they lose is potassium. So we have to be careful with patients that are on diuretics because they can get really low potassium levels. What are some foods that we know are high in potassium? Everybody knows the banana one. I don't know why that is. Kiwi is too? Oh, I love kiwi. It's a pain to peel, but it tastes great. Yeah. I'm not sure about that. But the big ones that are easy and cheap that you can tell patients, because kiwi, they may be like, oh boy, $1 a piece maybe sometimes in the off season. But bananas are cheap, but the bad thing about bananas is they're constipating. So old people don't like to eat lots of bananas because it'll bind them up. But potatoes are a rich source of potassium. So we don't see too many potassium deficiencies here in the United States because we like to eat our potatoes, right? Mashed, French fried, hash browns, whatever. But we can lose potassium when we give people diuretics, which are medications that act on the nephron to stop what process? Of the three we talked about. A diuretic will stop. Yeah, very good. Reabsorption. It's going to stop reabsorption. And it could be reabsorption of sodium because what do we know? Water follows solute, right? So if I reabsorb sodium, what's going to follow it? Water. So medications commonly act on the kidney for diuretics either act on sodium or water. Reabsorption, right? So they block that reabsorption, keep it in the nephron, make people pee. All right, so we will stop, and the rest of the lecture is online. So you can look at that in the next video.